All right. Hi, Ian. Hi, Dana. Hi, Sophia. Feel free to ask your questions of Dr. Goldberg. We're here today to talk all things laser. Unfortunately, I'm not seeing any of the questions, so I'm looking at them at my phone. Sorry, because my screen is black except for our two pictures. But it's okay. We're going to figure this out and we'll get it to work. So welcome, Dr. Goldberg. Dr. Jerry Goldberg hails from the warm state of Arizona. I don't know if you got hit with any of this cold weather, but
it's been really freezing. We actually had to put a sweater on yesterday. It got as low as 45 degrees. So we're really hurting here.
Wow, that's really cold for you. And we just dug out at 18 inches of snow.
I know. I heard you got really blanketed.
Yep. So
I'm seeing questions on the side. Are you Aaliyah Lar and Krista Poole?
Yes, I'm starting to see them on my phone.
Yes, I can see you all. Krista has a question.
Okay, but okay. Let me just try to get to them.
Tracy Bradley.
I know I'm having some issues. So I see, hi, Ilya. Hi, Sophia. Hi, Krista. Hello, this is Teresa Bradley. This is your first question, Dr. Goldberg. And by the way, Dr. Goldberg has over 40 years experience treating vascular birthmarks. Dr. Goldberg did a test patch on my lower cheek near my jawline at the October clinic, and it was successful. The Joule setting was 9.25, 1.5, 10 millimeter, spot size 3D-CD. Would there be any reason to change those settings if I'm treating my full birthmark, which covers the right side of my face, if I have overgrowth at my lip? Would it be appropriate to layer the laser there, and what setting would be good for that? 5 years ago, I had debulking at my cheek. That area feels softer to the touch. Would there be any need to reduce the settings?
Thanks for the question. So you had the settings that you see here. You know, I kind of want to defocus about settings, at least for most applications, because things can change. You could be tanned one time. The condition of your skin may be different, more reactive, less reactive. So I typically will watch the reaction to the skin when I'm treating. So to be focused totally on that number can be deceiving or not that important. That's certainly a ballpark setting and perfectly good. You can repeat that setting sometimes to get more oomph. I'll do you mentioned it here, layering the laser. And I'll often layer what I call a non-purple creating setting, non-purpuric setting, we call it, and then layer on a purpuric setting right on top. But having said that, if you have a successful first stage, as you note there, you can either do that or slightly notch it up a little bit if there were no adverse reaction. And then on the lip where it's thicker, I would probably layer on a deeper penetrating laser. There's some controversy which laser you would do first. I'll use typically an infrared, a short infrared 1064 long pulse laser for the deeper elements, and then use the 595 pulse dye in this case subsequently. If your lip is quite thick, it may at some point again require some kind of debulking, because the laser itself may not be sufficient to get the job done to really get the bulk of the lip down. It really depends. I'm looking at you. Were there any? Is Teresa? Can she respond to my question?
Yes, she's on, so she.
Are you there, Teresa? Anybody home? Teresa, are you there?
Krista. Oh, Teresa Bradley. I guess Teresa it was Bradley. Under Krista Poole.
So, Teresa, do you have any other thickenings on the cheek? Any other nodules or thickened areas?
She's probably typing. We're just not seeing it yet. And I am now seeing.
Oh, she can't respond.
Not real.
Yes.
We
said yes.
Okay, yes.
That's yes to there are thickenings elsewhere. So in those thickened areas, what I typically do would use, and Roy Geronimos may do a little bit differently. He tends to use the 1064 long pulse first. I tend to use the 595 pulse dye laser first, and then subsequently treat would be 1064. I don't know that it makes all that much difference, but you're trying to get flattening of any thickened elements without getting any breakdown of the surface of the skin, or as little as possible. Sometimes you have a very thick bleb or thick skin, you will get some breakdown, but that will allow for optimal shrinkage as well of the skin. So yeah, I don't know how much more specific I could be without seeing the result visually of your test spot. If it's imperfect and there was no side effects, you could potentially go a little bit higher, or you could go at a shorter pulse duration, 0.45 pulse duration at the same joule setting, kind of depending on the size of the vessels. If you have very fine vessels, you want to go with a shorter pulse duration. I mean, these are technical things that we would be adjusting real time as we do your treatment, or we would do additional test spots with a shorter pulse duration on part of the port wine stain and a longer pulse duration on others with slightly different joule settings depending on the skin response. So again, instead of just focusing on you must have 9.25, every device is different. So if you use a different device, using 9.25 in this device may be different than the next device. That's why instead of focusing on your numbers, I focus on what the skin is looking like after initial pulsing, so it can help gauge and help us alter the pulse settings or the settings of the laser as we're going intraoperatively. Does that answer your question?
Yes, I think that was a great answer. And also,
so nodules, we do tend to layer and use
yes,
double lasers. In other words,
yeah.
different wavelengths, or at least different pulse durations. If we only have a 595, you use a short pulse, longer pulse. The longer pulse being more deeply penetrating, ideally with a largest spot size possible. If you have a 12, that's often good to get a little deeper penetration. The newer devices, the V-Beam Pro has a 12 and a 15, 13, 14, 15 millimeter spots, and those are useful to get greater depth of penetration of the laser beam.
Great. So we have some more questions coming in, but so you all know, Dr. Goldberg will be doing laser at our conference, our clinic in October in New York City. And he'll also be, for those of you international, in Bucharest with us in July. And he will have dual pulses for people who have thickened or blebs or small venous lesions. So he will be at both places, and both of those will be free. You can get more information about both of those on our website at birthmark.org. The next question comes from Ilya Lair. She wants to know, can a darker skinned baby get laser done? His dermatologist said it wasn't an option since it would make his skin lighter than the skin color. Should I get a biopsy done?
No biopsy is necessary. Are we talking about black skin? Are we talking about Hispanic, Asian, or just tanned skin that tans easily and typically with darker eyes, brown eyes, or that would be a skin type? Do we know what kind of skin type? Because if it's skin type, what we call 3 or 4, which is basically tans easily, can burn, but with some difficulty, brown eyes, dark hair, typically we make some adjustments. The two main adjustments in treatment are to increase the cooling, to decrease the interaction or the competition with pigment in the skin, and we can elongate the pulse duration, which also would make it less apt to hit the pigment of the skin. So again, we'll do a test pulse, make sure we don't get any blistering or effacement of the surface of the skin, and then proceed cautiously with more cooling. Either, you can use ice, but certainly increasing the DCD so you get more surface cooling on the surface. And then, as I said, elongate. Instead of 1.5 pulse duration, we may use a 3 millisecond pulse duration and pump up the fluence a little bit, the joules, and also make sure our cooling is optimal. So a couple things. Instead of a biopsy, we're talking about test spots. We want to do it with different pulse durations and lots of either ice and or increased DCD, always for darker skin babies. So they can be done safely, but much more tricky to treat, particularly really darker skin types. But we've treated black skin and certainly Hispanic and Asian darker skin types safely and effectively.
Yes, I was going to say Dr. G treats all 6 skin types, right? From super fair to super dark with port wine. You got to be cautious. You got to go slow. You got to look when you hit that, zap it at what color it turns, and then you adjust accordingly. But it's.
And also the color is difficult to monitor because you don't get the typical purpuric endpoint, that purplish bruise-like endpoint that we often look for. But that may not even be critical in the treatment. So we do advise on darker skin types, particularly where it's tricky, to do a series of different test spots with different fluences to see what works the best.
So we got a lot of questions coming in. So Tina has a question. I have a port wine on the right cheek and over the left eye. I get fluid swelling over my left eye with occipital pain. Is this PWS related?
Wow, I that's going to be a tough one. I don't know what you mean by fluid over my left eye. Is that in the eyelid skin, or is it in the periorbital around the eye? Let's see, occipital. We're talking occipital pain. That's different because that's occipital's in the back of your head, which is not where the left, where the surface would necessarily go. But fluid swelling over my left eye, I guess I need more specific information about it. I can't dismiss it entirely. It certainly could potentially be consistent with right cheek and over the left eye, fluid over swelling of my left eye. So there is no port wine stain on the left side. Am I reading that correctly?
Yeah, I have a port wine.
I see a port wine on the right side.
No, on the right
on the left eye.
She has it on her right cheek and over her left eye.
I'm sorry. The port wine stain is also over the left eye.
Yes. So
I see over the left eye. I presume that means over the eyebrow and also involving the eyelid. And certainly eyelid swelling can occur with port wine stain on the eyelid, particularly because you really don't have any buffer. There's no bony help there, so you can get significant swelling of the subcutaneous tissue there, even if you lightly hit it with a laser. So that's something to be cautious about. It may very well be related to the port wine stain over the eye as well. So I think caution again. I think you can sometimes you can pre-treat with cortisone as well if you're concerned about swelling. That sometimes can mitigate significant swelling. And again, small test site areas if you're concerned about treating around the left eye. And if it still persists, you can do imaging that might help to see if there's some other deeper feeder vessels in and around the eye that can be leading to increased fluid around the eye. So I think caution, number one, potentially using something to decrease swelling, whether it's ice again, or steroid prior to treatment or after treatment to decrease swelling, and then test spots, and then potentially imaging. So those are the things I'd look for.
Yeah, and I'd also want to chime in, Tina, because we have a new glaucoma expert with VBF, and he and I are working on a little fact book. And the swelling, you're going to need a glaucoma check, but it's not
very good point. I meant because if it is over the left eye, not so much if it's on the lateral side, but if it's around this central portion, we call medial, right around the nasal bridge, right up in the root here and the inside of the left eye. If it's in this area, there can very well be associated glaucoma. It's a very good point.
Or not just glaucoma, because sometimes it can be choroidal hemangioma or retinal problem. And we see the choroidal with fluid. That's why it's very important for her to go and get I think that's
very good advice to make sure you get an ophthalmologist involved as well. And they can help guide whether you need imaging or what kind of imaging to eventually get to see.
Right. Probably, Tiana, see a retinal specialist, because they can do that orbital angio and go right behind and get a real good 3D image of everything going on, because you don't want to mess with that. You don't want to mess with it. Hi, Mary Scanlon, Dr. Goldberg. We live in Ireland. I have a 10-year-old son with a large port wine stain going from the small of his back all over his left leg. He has never had any treatment. We were told by the doctors that laser treatment did not work on extremities. This was 6 years ago. Have lasers improved, and do they now work on the legs?
Well, number one, it's just on the one leg. Is that correct? I'm presuming.
Yes.
So the first thing to consider is if there's any discrepancy in the girth or circumference of the leg. Sometimes there's an asymmetry, which can be related to the asymmetric port wine stain on the leg, the so-called Klippel-Trenaunay syndrome. So that you'd want to look into that if there is some significant discrepancy. If there is, that can often be more difficult to treat. But to answer the second part of the question, 6 years ago, lasers have improved. We have the newer V-Beam Pro, which again has a bigger spot size, which allows for deeper penetration and areas can be treated more efficiently because of the larger spot. So these are large areas of port wine stain, you're saying. So you can treat these areas more efficiently. Particularly, Dr. Geronimus has a considerable experience in treating massive port wine stains with the new Pro, the V-Beam Pro. He tends to want to see folks early in the first years of life again, when the lesion is thinner, more accessible to laser treatment. Once you're maturing, even at the tender age of 10, they can be more resistant to treatment than they would be in the infancy in the first years of life. So having said that, it's still worth going after that. I mean, these are typically asymptomatic and not functionally important unless I said there's leg length discrepancy and girth discrepancy of the extremity, because that can increase with age and be more of an issue in terms of leg length discrepancy in the Klippel-Trenaunay syndrome. So I check that out in terms of discrepancy of the size of the leg, and then it's a very personal decision in terms of going ahead with treatment at this stage. You certainly have very little to lose to doing test spots. Ideally, if you can find a practice that has the V-Beam Pro, that's the one to use.
She's in the UK. They don't.
Aha!
She's
UK, Ireland. Got it.
She's in Ireland. So
I go to Malaysia to get a Pro.
Yeah, no, she but Mary, you can come to our free clinic in Bucharest, and Dr. Goldberg can do a test spot, and you can even wait around, see how it responds. And he can tell, looking at how the capillaries respond to the laser, if it's going to be effective, and then you could get like a full treatment. Or you could go see Dr. Coletti, who's in Italy, and he can do a test spot for you. I can arrange for a test spot done for you if you want to just see how that would work. But also what Dr. Goldberg said is, number one, you want to make sure it is a port wine capillary malformation, because sometimes there's red on legs and they can be like angiokeratomas or verrucous or something like that. So you can feel free to send Dr. Goldberg pictures, because then if we do see you in Italy or Bucharest, he'll be familiar, and he can also just say, yep, this is just a straight port wine and this is what I would do. And Debbie or Kiana can just post, if you can post Dr. Goldberg's email into the comment, and then anyone who wants to send him a picture, he's open to looking at your pictures and giving you comments. So thank you for that one, Mary. Thank you for that. Krista said you are looking. Krista, yeah. Oh, purpura then. You're looking for the purpura.
Yeah, typically that's the endpoint I typically use when we're looking for effectiveness of test spots or treatment intraoperatively as well.
Yep. So Maeve says, hello, thank you so much for these information sessions. I'm 50. I have had dozens of PDL. My port wine is over half my forehead and over my eye. The treatment received varies much depending on who carries out the treatment. Well, that's true. Everybody has a different methodology. I had the best treatment in London at St. John's Institute. I had black bruising and significant swelling over my eye. It resulted in some fading. When I changed clinic due to funding, it has never been the same. the reason is given. I don't know what, that's it. Never been the same. So again, we have the free treatment clinic in Bucharest. You could come.
So what is the question then? Your question is, does treatment vary by the operator? And it does.
Yes.
Some are more aggressive. The black bruising you're saying is significant swelling is kind of the endpoint that I often use, just short of, again, creating any abrasion of the skin or breakdown of the surface of the skin. And there are many ways of altering or amplifying the response by layering, as I said, as I've done before. So there are some little tricks to use. But, you know, these are hard because these vessels do recur. They do have a response, this so-called neoangiogenesis, this new blood vessel formation. And I'm trying to get these studies, gets people interested in these studies to use a medical agent that we know blocks angiogenesis or new blood vessel formation to be used prior to treatment and after treatment to see if we can decrease the rate of these recurrences, which are really difficult to live. I mean, you go through all this and it's looking decent, and then over time it comes back. So it's very discouraging. I know we had dozens and dozens of treatments. So we're always looking for better and better ways of doing things. And I'm hopeful in coming in the future that we'll have a medical device as well as just optimizing laser device. So laser plus some medical intervention. And we've looked at these angiogenic factors. Stu Nelson, a dozen years ago, had a very promising result with rapamycin, at least in a mouse model, but it never really panned out when we used it. And I've used it quite a few patients over the years. But we're still looking for that magic bullet that will help decrease recurrences. One I'm looking at is called imatinib, Gleevec, and I'm hopefully that I can get people with very active practices like Stuart or Roy to do this study with us that we're trying to carry out. So stay tuned on that.
We have another study going on over in Connecticut where resistant stains are being treated with sclerotherapy, where he's mapping out the engorged vessels and then treating them with the laser. And we're pretty optimistic about that.
When you say mapping out, what are we mapping out?
He's using ultrasound and guidance.
That's for venous combination venous?
Well, yeah, because in some of the extremity lesions, you're seeing venous involvement below the capillary stain. So Nasseri is treating that and then following up with sending them to Roy to see if we can get more clearance, because that below venous is feeding back to the capillaries.
Yeah.
So there's a lot going on, and it's exciting.
I do a lot of those, the so-called vascular malformations with a mixed venous, capillary venous with a venous component. Yeah, and those are tricky, but can be handled again with the long pulse lasers as well. And I know Roy has a protocol. He's using the Myria laser, which is a 1550 non-ablative on top of this, and we've used fractional CO2 over thickened lesions. I know,
but I think that has
Dr. Hoxeta in Spain uses a fully ablative for nodules and whatnot. So many different ways to go to enhance results, particularly with thickened lesions. But these, what I call ordinary or kind of
routine
kind of port wine stains that are flat, pink, red, and not nodular, those can be, very challenging over time. So sticking with it, I think, and getting additional tweaks, maybe using that non-ablative technique on top of the laser is another way to go. The pulse dye laser, I mean. So looking for layering the different pulses by duration, the pulse duration, as well as the fluence, having a non-preperk pass and then a preperk pass. It can enhance treatment results with those techniques as well.
So we have a lot of questions coming in, but I wanted to just dial back. So Ilya Lair said they're Hispanic. And just for the sake of everybody that's on, just keep in mind that like one is me, creamy, fair skinned, and 6 can be very dark, like Michael Jordan, the basketball player. So if you can kind of say, oh, we're like around a 2 or a 3, that helps Dr. Goldberg with knowing how to respond to you when you're saying, you know, what the birthmark is and your skin type, because they always adjust the settings based on your skin type if you want to get an effective treatment, because you can either hypopigment or hyperpigment, and you don't want that, even though it can resolve. Ian Pegler, he wanted to know if he could record this. He's doing a study, not off of this, Ian, but we will upload this to our YouTube channel. So please reach out to Kiana, Kiana, at birthmark.org, and tomorrow, and she or the day after will give you the link for the full YouTube video, and you can include that in your study. Okay, do you?
Actually, I did get an email from Ian. So Ian, we'll set up a phone call if you want a phone interview.
Yes, I gave him yours and Dr. Cohen's because he's doing this study.
Right.
Thank you, Ian. Okay, so Angie, do you provide treatment in BRBNS in the GI tract? She's having success with sirolimus right now.
BRBNS.
Blue rubber bleb.
Okay. Yeah. In the GI tract.
Well, that sounds like that could be Cowden's syndrome. They should get that.
I think sirolimus is probably your best bet. I mean, that is. I'm not up to date on all the data on blue rubber bleb in the GI tract, no less. So there are lesions on the skin as well, I presume. I'm not sure.
Well, it can be or not. It can all be just GI.
Sirolimus, if you're having success, I'd stick with it. If there are other alternative anti-angiogenic, again, I would do a search on that and discuss that with your treating physician.
And also Dr. Rosen and Dr. Matei in New York City at the Lenox Hill Hospital, they do treat GI tract lesions. And if you email me at vbfpresident@gmail.com, and I think Deb or Kiana can put my email in there, then I will give you his email and you can write to him directly, because he is treating GI related vascular lesions, including blue rubber bleb nevus. And those are not easy. So make sure you go to an expert. Sophia says, hi, Dr. Linda and Dr. Goldberg. Our 10-month-old had 8 lasers so far, done every 4 weeks. Because bruising takes almost 3 weeks to heal, we're unsure if we're seeing the true end result. We're considering taking a short break to assess lightening. Is there any risk that spacing treatments or pausing could cause the birthmark to darken again?
Well, this is a tough one because there are many different protocols. Actually, Dr. Geronimus is treating every even 1 to 2 weeks, non-purpuric, and is getting very good results. So that brings up the question, particularly in infants, newborn, neonates, basically the first year of life. There are advantages to getting started in the first year of life. If you hold off until 15 months, 20 months, kids, as you know, at that stage are very difficult to treat in an outpatient setting without significant sedation or even general anesthesia. Whereas most of the time, the first months of life, we can do it comfortably, or not so comfortable for the baby, but we can do the treatments without the added risk of general anesthesia or big time sedation. So this all points to trying, as you've done, to treat pretty aggressively in the first year of life. And it's not uncommon for the bruising to last a couple of weeks. 3 weeks is a little long most of the time. And to take a short break would be okay, but these will recur and redarken. And then you're at a window where it's much more difficult to treat. So this is one of these balancing acts where you want to be aggressive in the first year of life. You want to do it in the least traumatic, or I shouldn't say traumatic because without general anesthesia can be traumatic, but safest with less risk of anesthesia risks adding on top of it. You want to get as many treatments in as you've done in that first year of life to get an optimal result. The port wine stem itself is thinner, more accessible to the laser as well. So those are reasons that you want to be moderately aggressive. So I guess the other way you could go is looking at some of Roy Geronimus's protocols, where you're, instead of having a prolonged pause, do a less aggressive non-purpuric settings for a couple treatments and see if you can't do them still at 3 to 4 week intervals, 2 to 4 week intervals, and get continued lightening before you hit that period where a child's kind of unmanageable without general anesthesia. So I guess what I would say is, yes, pausing would risk, yes, it will darken again, but also you'll get in that period where we would either skip until the child is really comfortable, if you want to do it without anesthesia, or doing it with general anesthesia. Or, as I said, I'd back off perhaps on the parameters a little less aggressively, non-purpuric, and see if you can get some nice results over a period of another couple months.
Okay, thank you for that. We have 27 minutes left to answer your questions, so we got to get moving through these. And those of you, if you're telling us that you have a port wine or venous or something, make sure you describe it. So this question is, if you have a venous malformation on the face, can you have laser to lighten it? That's a good question for you. So go ahead and answer.
Well, there's Tiana's following up with inner eye and any vein relation. I don't know what you mean by inner eye when you say, because that was the question with fluid on the eye, right? Fluid.
Right, but we have to get through these other ones.
Yeah. So I'm not clear where the swelling is. So
right, she needs to see an ophthalmologist, that can study that.
So left eyelid is what they said. Okay.
Right. So we've got to get through these new
ones. If you have venous malformations in the face, can you laser light? Yes. I've treated quite a few venous malformations. That's kind of one of my favorite
not a lot of doctors do. You're the leader of this.
It's one of my favorite things to treat. I wish we had some visuals I could show you. But the venous malformation, again, I use combination of therapies. So I'd use the long pulse. Ideally, 1064 works very nicely in combination with either a 532 or 595 laser. So you kind of layer the two together, multiple sessions at several week to month intervals. And you can lighten and flatten these venous malformations, which is the key, particularly if it's in a sensitive area around the mouth, around the eyes, around the lip. Lip can be more resistant than other areas, in my experience. But yes, the answer is yes. And get someone with some experience to help you with that.
And remember, he's going to be at the Bucharest clinic in July and at the VBF clinic in New York in October. And he will be wielding multiple lasers in his room because we send all the thick and venous malformations to him because he does them the best. Any occasion with venous congestion with port wine stain over head or face?
Vein congestion.
It can always happen.
Yeah, and what you need, if you are concerned about that, this is the same thing as the swelling around the eyelid, you may be looking at the need to get some imaging done. And imaging can be done to make sure that you're not missing an arterial venous component, and certainly, or a venous, capillary venous mixed malformation. So I think with those kinds of questions, if it's, first thing you do is simple things like, listen for high flow lesion, or get a Doppler and see if it's warm to the touch. I mean, that all tells you if it's high flow. So I would be concerned with these questions to make sure you're ruling out capillary venous, and more importantly, the arterial venous malformations.
And a lot of what she's saying does line up with a choroidal hemangioma. So again, when she gets her retinal, sees a retinal specialist and has a good workup. And you can write me back, Tiana, and email me and tell me what you found out.
Sounds like glaucoma testing is good. So I wonder if
and that's why
further discussion about that, or imaging.
That's why I think it's the choroid. So
it's imaging.
Got to get going. Why is imaging not done as standard for port wine stains? Well, basically because very few people believe in treating, and insurance doesn't even like covering treatments of the laser, let alone imaging. However, VBF introduced the ultrasound at all clinics to ultrasound every birthmark before we treat it so that we can make sure there's no underlying venous or arterial venous malformation. And I've been pushing it, and I'll be at ISFA this spring, and hopefully we'll be able to submit a paper about the necessity of doing ultrasound before, or imaging before lasering, especially for some of these lesions that don't behave like a normal port wine. Or a real caution is if you've had 8 or 10 treatments and you see zero clearance and it just fills back up and you can put your hand on it and it feels a little warm, you want to get an ultrasound.
You bet. You bet. But and the imaging is not imaging. I mean, you can do ultrasounds, you can do MRIs with venous or arterial contrast. And now OCT is available, which shows you size and depth of vessels. And there are other imaging techniques out there being worked on as well. But so imaging can be a lot of different things.
And Mary,
the left leg.
Yeah. So Mary, I just want to tell you, please try to come to Bucharest because Dr. Coletti will be there and he does treat these. And I mean, you'd have to go to Italy, but I'm saying you can get the laser and the overgrowth both taken care of by the same person. He knows how to do these.
And, with the overgrowth, it very commonly has an associated venous component that needs to be dealt with, even with sclerotherapy or other types of therapies.
Yep. So Maeve says, sorry, my question must have gone through. It was asking if imaging to determine blood vessel depth and width would help. And does the new laser help resistant? So most of the ultrasounds can tell you if it's capillary, lymphatic, venous, or arterial. And you can kind of get an idea of how deep it is. And this is a good question because, as Dr. Goldberg says, the laser only penetrates 1 to 1.5 mil. But like I try to explain to people, the capillaries in a port wine, they weave. They're not all just right here. They can be here, here, here. Like they just weave. And
different sizes, caliber of vessels, depth of vessels. So they're very heterogeneous. And you see that particularly with OCT devices. There are a few people around who are doing that, particularly with resistant ones, to help guide therapy. But my only critique of that is there are very few ways that you can modify your treatments to hit these blood vessel depths. You can I tend to do it empirically, meaning if I haven't felt I've hit deep vessels or bigger caliber vessels, I'll change the parameters. I'll use a longer pulse width on a 595. I'll add a 1064 deeper penetrating infrared laser. So there are different ways to hit the different blood vessel depths and calibers to optimize treatment. That's why I like the layering approach in a resistant port wine stain. I think that makes a lot of sense. Unless and whether it's OCT guided or not, that'll at least help cover the playing field to make sure you've covered the different vessel sizes, calibers, depths in these heterogeneous lesions.
That's great. So Emily says, just a quick question while it's on the topic of laser. Is laser recommended for large infantile hemangioma? Oh, hi, Emily. It just popped in my head who you are. She has an adorable little boy, and he has a intraorbital hemangioma. It's there. And I've been communicating with her.
The eyelid periorbital.
Well, he's suspect for face syndrome, but I don't think his dosing is correct. And
I think that'd be the first thing I look at would be the dosing, because it's very unusual to see no change with propranolol. I mean, it often is underdosed. So I don't know how old the baby is.
He's only a couple months old.
Okay. So typically at about 6-8 weeks is when these things tend to expand if they're not already there at birth. So this is a typical infantile hemangioma. So I would tend to boost up the dose. It should be closer to 3 milligrams per kilo per day. And
right. And
some people get a little hesitant. You give one test dose with one, and then inch up to 2. And
Yeah.
I would just, if it's not responding, it's important to monitor and make sure there's no adverse effects.
Yeah,
Blood pressure, no
yeah.
bronchial issues, blood pressure, pulse, this kind of thing, and just general lethargy. Those would be signs that you're being overdosed. But that'd be the first thing to attack would be the dosing.
I've been in communication with her because I'm really
Well, I
worried.
see 6.5
I know.
milliliters 3 times a day. I don't know what 6.5 milliliters. So I assume is that
He's pretty big. How much?
for 5
does he-
per ml or 15 per ml? I imagine it's 5 per ml. Well, that's pretty good dose. 3 times a day at 6.5.
Well,
You have to see what
that's 19.5.
that's milligrams. Is that what?
Yes, she put milliliters, but
So they're different concentrations. So I have to
yeah.
imagine that's
I don't think it was milliliter. Well, I
I
don't
see
know.
ml, but
I know. That
I
doesn't.
imagine it's mg, so it is 18, 19,
Because he was on a really low dose.
and I imagine the baby's
Well,
about,
just look at the bottle, Emily, because I've been talking to her a lot about this because it's just too long. And the other question is, it does act like and look like an infantile hemangioma, but there's something different about this one. So
you may
maybe
need some imaging to make sure you're not
or a biopsy
underlying venous or some
or
other.
or a biopsy.
Is it really meningioma? Could it be a nasal glioma or something?
Right.
Different. So often, if it's firm, particularly, these should be spongy, and if it's very firm, it could be other entities as well. So biopsy could also be useful.
Yep. I see a lot of people are
5
on.
milligrams for 5 ml. Okay, so you're at 6.3, you're at 19 milligrams. That's pretty good dose. I presume he's 5 kilos maybe or 6 kilos. So that's 3 per kilo per day. If it's really.
Well, I actually wanted them to add steroids to it because
that would be another way to go. If we're comfortable, he's on maximum dose for his weight. Or there's still no change. Told that we may see change around 1 year of age. Well, I want to make sure that it's not occluding the eye, right? Is it?
It is.
Occluding the eye. It's
it
very
is.
important to get that eye open. So I would definitely hit it with steroids.
He's
Oral
trying.
systemic steroid for
He's trying to
short
open
burst. That was our main tool before we had propranolol. We used to use systemic steroids for fairly short periods of time. We don't want to be on months and months, but for 4 to 6 weeks at least.
Just to get even
alternate day steroids. You can do it, give them a burst daily for a week to 2 weeks, and go to alternate day to get an optimal response. And that's what I would definitely add at this stage if it is maximally dosing.
Yes.
If that's not working, I'd look at a biopsy. I'd look at imaging as well, making sure that there's not some underlying additional deeper vascular component.
And we've been in touch, so I've been helping her along the way, and hopefully he'll get that eye.
And if there's a occlusion of that eye, you wouldn't wait around for a year of age for something to happen. I would definitely hit it with steroids because you can get suppression of that you get amblyopia. In other words, suppression of the image. So ultimately, when the baby's visual system matures more, they won't have binocular vision that's together. So it's really important that the brain gets stimulated from that side of the eye to get optimal depth of field and binocular vision.
Yep, we've been talking. So we've got less than 15 minutes. So Lucy writes in, my 17-month-old was scheduled for laser, but it got rescheduled for June when she'll be 22 months. Is it recommended for them to be sedated at that age, or could we do it? Oh, I got so many coming in. I got to look on them on here because I lost them.
It's let's see.
Yeah.
22 months. Now, what is it? Is it a hemangioma or a port wine stain? Do we know? If it's hemangioma, circumference of a dime.
She has an infantile hemangioma.
Okay.
It's the circumference of a
dime. That's minuscule.
Yeah.
I certainly wouldn't use significant sedation. That's something I would use talk aesthesia, distract.
I would just, if that's why not even just Timolol?
Yeah, the first thing would be, has the baby been on Timolol? Because that would be a nice adjunct. Propranolol is overkill for that small a lesion. And most of these will, if it's not occluding a vital structure, you can just watch it and you can hit it lightly with the laser, which only take a couple pulses, one pulse if it's a dime size on the temple particularly. And I do a little distractesthesia, and if you want to give a little Benadryl or something, just lightly sedate, that would be fine. But I wouldn't do anything much heavier than that, or Atarax, something like that.
Yeah, Krista is just reminding us, we did talk that I squeezed her in at the last minute in the clinic, and she was your first case. Krista was.
Yeah, I remember we just did a test. I was trying to lean on Krista to do, or Teresa to do a little more than just a test. But she was not that comfortable doing it, which is fine. I mean, you got to get comfortable with, there's a lot going on. Obviously, we've had it for a while, and naturally you'd be concerned about, what happens with the laser. But at this stage, I would do additional treatment if you're up for it.
Yep. Come, Teresa. So Vinadini says he has an 18-month-old Asian skin. Thank you for telling us. Port wine over the left cheek, V2 region, 6 lasers, 7 mil, 0.45, 7.5 to 10 joule. Okay. There's some clearance, but not as expected. But these are the settings followed here, and this is the frequency accepted here. What else can we do? Would increasing the MS help? How do we assess if the capillaries are too large or if it's deeper than the PDL is not penetrating?
Yeah, I think a couple things are missing. Number one, I would make sure you're using the optimal spot size. The 7 millimeter is kind of small. You should have at least a 10 available. And on darker skin, I wouldn't jump to 0.45 millisecond. I would definitely use a longer millisecond and still be up at a higher setting to get a light purpuric endpoint. So again, doing tests with the different pulse duration. The pulse duration is a little short for my liking, and I want a bigger spot size, and I want to make sure the DCD. I don't see a DCD number on there. I would make sure it's up at 40 millisecond or so DCD if you have darker skin. And,
that's the cooling device.
Yeah, the cooling device. You want to optimize the cooling to decrease the interference, the competition with melanin in the skin. So that, yes, increasing the millisecond would help. How do we assess they're too large? I don't know that they're too large, but certainly with a 0.45 millisecond, you're not going to get large vessels as effectively as with a 1.5 or even a 3 millisecond pulse duration will be more effective for larger vessels. So if you're concerned about that, again, you could do a layering technique where you want to do a non-purpuric with a 3 millisecond spot, a big spot, 10 millimeter spot, 3 millisecond, and ramp up your joules and ramp up your cooling, and then do a lightly purpuric one at 1.5, something like that would be how I might approach it. So yeah, there are techniques to tweak the laser to make it more effective.
Thank you for that. So Lucy, I would definitely stop the Timolol if she's having horrific sleep problems, because there are babies that are just super sensitive to beta blockers, and we know this. And it's so small by the temple. Find out where one of our laser experts are, probably a couple zaps since it's so little, and it'll be over and done with. So you can look on our website at birthmark.org where you live.
I can't imagine you get enough systemic systemic absorption with Timolol on a dime-sized lesion, but I guess
well, it depends on how much she's putting on and how frequently.
Well, I'm saying it. I don't know that.
I know.
I wouldn't peg the sleeping on the Timolol, to be honest. But having said that, if it's that small and it's not functionally important, I don't think there's any urgency to getting too aggressive on this, because it should shrink. And then when the child is, if still bothered by it on the temple, that you can do it when she's on board and motivated to treat, even at age 4 or 5. It'd be simple to give her a couple pulses with a pulse dye laser.
You wouldn't do it now, though, just a couple?
Yeah, you certainly could. I think that is certainly worth doing. Okay. Particularly, as I said, do a little talkesthesia, distractesthesia, a couple pulses, and it's done in 3 seconds.
Okay. So I'm looking through lots of people on. Hi, Trisha. Trisha Dolce's on. So we've only got the precious Dr. G here for 7 more minutes. So let's get those questions in before we wrap up. But I'm glad you mentioned the Maria, because I did have it on my face and it is great for tightening. But Dr. Geronimus is using it on treatment resistant port wines, and he's seeing a great result with it. More of the Derma V coming out, Cytons, BBL, the Clear. There's a lot of competition. Although the Pro is the gold standard, the Pro still has not been distributed worldwide due to the tariffs. It's been sitting in Malaysia and all that. But more and more people are, you know, but the Pro, the beauty of it is it goes deeper, it's quicker, it's a bigger spot size. It has cooling before and after, so pre and post cooling, and almost very little purpura. So that's why everybody likes it, because it's like the home run of laser.
So a couple more questions here.
I see that. Okay, so what are your thoughts on multiple laser sessions a week? 3-month-old daughter started at 2 weeks with PWS, because Roy's doing them daily. So
2 times a week. Well, you're obviously seeing Dr. Geronimus, because he's one of the few in the world doing them that frequently, and it's non-purpuric. And the idea is it inhibits that quick neoangiogenesis response by cutting it. Any new vessels that are thinking of starting to be forming, you're knocking them back again and again. But so the jury's still out on that. So I don't know that I can comment very effectively as to this approach versus others. But Roy's had very good success with doing frequent. I saw and talked to him about weekly treatments, but I understand he has been doing some 2 times a week. And I think
we did a 5 and 5 study where we did 5 days in a row, right, 5 laser treatments, and there were 5 babies, and 3 of them had complete clearance, and one of them needed a 6 treatment and then got complete clearance, and the other one that had Fitzpatrick skin type 3 is needing more. And that
my only question there is, and I've talked to Roy about this, I've had complete clearing on a lot of port wine stains in the first year of life. I see them back at age 6 or age 8, age 12, and they have recurrent port wine stains. So it's not like you're done.
I know.
That, so I'd be a little questionable about that. And I'd also like to see a control area where you do regular 1 week or 3 week intervals to see if the clearing at a year is, I mean, that would be a much more impressive result, because I like to see how those people do that clear at, say, 2 months of age and how you're looking at 8 months.
Yeah, we need to do a lot of prospective.
Krista said, can you layer with 595? Yes, as I mentioned, 595 alone, you could use different pulse durations, different joules. You can do a non-purpuric pass and a purpuric pass, Peter Piper Pectopac, with the 595. So yes, you can layer just with 595 and optimize, get more optimal result.
Oh, here's a good one. Beth is saying, would you delay treatment in an 11-month-old who already has had 13 sessions with moderate improvement with an earlier laser, waiting for the new Pro? We were supposed to have it here in Boston, we know, and are scheduled to keep going every 3 weeks, but no improvement. Why?
Yeah, that's a little odd. Again, I might suggest while you're waiting for the Pro and you're at 11 months when you still can manage the baby without general anesthesia, to consider, again, some of the other techniques we talked about, layering 595 with different pulse durations, doing a double pass. But the new Pro, it's not a magic bullet, but it is more effective. You can have bigger spot sizes, better depth of penetration, pre and post cooling, so it's more comfortable, and you can optimize the fluence with a bigger spot size. So that's all good. So,
when we premiered it at the clinic in 24, people who had not had laser because it was so painful in the 90s and early 2000s, they just raved about it because they were like, oh my God, this is just so great. Would laser sessions be? Yes, we're going to have the laser in Bucharest for everyone who registers. You got to register at our website at birthmark.org. There will be no general anesthesia. And if it's a baby, there's nothing. There's not topical, but it goes very fast. We have Dr. Goldberg is a pediatrician as well as a dermatologist, and we're bringing Leslie Graff, our child life specialist,
Great.
to do the comfort care with the babies. And if we're able to get the pro there, which we're working on, we're talking seconds with the new laser. So we're not talking the baby's going to be, there for 5 minutes or something. We're talking 30, 45 seconds. So you can come and try even a test spot and see if the baby will be all right, or you can let Leslie do the comfort care and let her take care of the baby and have the laser done, and the baby will be fine. So I'm just letting you know we do have that. We're pretty much getting close to the end, I think.
Yeah, I see Beth is following up on her question, deciding to go to New York City in October. And at that point, the baby will be, 17 months, something like that? Do I have that right? Another 5 months, 6 months?
Yeah.
Or more. So that's just a really tricky time, depending on the child and what the response has been. And if it's smaller than palm size, we can do that pretty effectively quickly with the pro. So, even at 18, 19 months. So I don't know what to tell you. I probably would do another session layering with the V-beam, regular V-beam, and the Perfecta, and then ideally treat again with a pro in New York would be a good, reasonable thing to do.
Well, Dr. Goldberg, it was quite a lively session, and I have to thank our silent partner, Debbie, who has been here and helping me facilitate and get us on this new streaming service. Once I figured out how to get the comments up here, everything worked out great. Great job as usual, Dr. Goldberg. His email is in here. He's very happy, very easygoing.
I actually have some time, which is good because I'm kind of semi-retired, which is good.
So
I've been at this for quite a while, and
and he can look at your pictures and give you feedback. But you can also have the privilege of meeting him in person and getting a treatment if you come to New York in October or to Bucharest in July. And you can find all that information on our website. And to stay tuned and up to date with all the latest developments in the treatment of vascular birthmarks, join us at birthmark.org. Thank you, Dr. G. Have a great night. Take care.
Thanks, everybody. Thanks, Linda.
Yep. Thank you.